All right, hello and welcome to week one. This week we are going to be looking at some general pathology mechanisms, primarily focusing on malignancy, cancer, and inflammation, both acute and chronic inflammation, and we'll talk about some autoimmune diseases as well. We're going to start off with just some general discussion on different tissue types, and we'll talk about some general definitions with respect to pathology and pathophysiology. So overall, Unit 1 is really a kind of an overview of things that we're going to be seeing in a lot more detail throughout the course. In each narrated PowerPoint presentation, I will give you the first slide showing you some key chapters and areas within the chapters that I want you to take a look at while you're studying, and then throughout the narration, I will be guiding you towards some key figures and tables in the various chapters that I also want you to take a look at. So, okay, let's go and dive in. And as you can see, this is just a slide here that's got a lot of different things on it. So again, throughout this course, we are going to try to hit the majority of organ systems, and we're going to be looking at things at both the gross level, visible to the naked eye, at the histologic level, which you have to see under the microscope, and then we'll also be doing a little bit of stuff related to the molecular level. And we won't get too deep into biochemistry or anything like that, but we do got to take a look at some molecular mechanisms because I think that will be important in helping you understand the disease and important in helping you with pharmacology. I'm a drug guy. I do a lot of pharmacology teaching, so I am going to give you some words of wisdom regarding pharmacology in each week. And you'll see what I mean as we move on here. All right, let's begin at the beginning. And remember, we all start out as a single-celled organism, a zygote. So when we get half of our DNA from mom and half of our DNA from dad, that full complement of DNA is then found in the zygote. That zygote goes through a number of mitotic events to eventually create our screaming bundle of joy that we see at the end there. But in between, we have a number of different tissue types. I guess we can call them primitive tissue types that are going to evolve, and those primitive tissue types are then going to make the adult or mature tissue that we are primarily going to be starting. So we can think of that zygote as the ultimate stem cell. That zygote has all the DNA that it requires to eventually become the different types of specialized cells that make up the human body. And as we move through this course, we're going to be talking about some of those specialized cells, and we certainly will be talking about some of that tissue as well. Epithelial cells. So we're going to look at the primary cells of the human body. Epithelial cells are cells which protect, cells which regulate secretion and absorption. We find epithelial cells which are lining the inner and outer layers of tissue. So outer cells, skin and mucosa, inner cells lining luminal surfaces such as bronchial tubes, GI tract, the uterus, any organ which is hollow is internally lined by epithelial cells. These cells can be present in single or multiple layers. They are typically tightly joined. They have what's called contact adhesion. They adhere to each other. They don't break off and get away from each other. They like to stay together. They rest on a basement membrane, and these epithelial cells should not cross through the basement membrane. That is extremely important, and we're going to talk about that property when we talk about cancer. And they have what's called polarity, apical and luminal polarity. Polarity meaning that they're lined up in a specific way. The apical side facing back towards the body, the luminal side either facing out of the body or facing outward into the lumen of the organ. And you'll see what I mean when we talk about cancer and what happens to epithelial cells when they lose things like contact adhesion, when they lose polarity, when they break through the basement membrane. That's not a good thing, and that's part of cancer, and we'll look at that as we move on. Another important thing to realize about epithelial cells is they don't have their own blood supply. All cells need oxygen, glucose, nutrients to live. That's brought to them via the vasculature system. The epithelial lining has no vasculature, so it is completely dependent on oxygen and nutrients diffusing from the tissue type below it into the epithelium. Connective tissue cells hold things together. Connective tissue is all about structural support. Connective tissue cells are typically arranged in an extracellular matrix. We have a number of different types of connective tissue. We have loose connective tissue, such as what we might see lining the walls of blood vessels or lining the walls of the GI tract. We have dense connective tissue, which is a lot more rigid. We see that in bone. We see that in cartilage. And very interesting, blood is considered to be connective tissues. Blood cells come from, in terms of embryology and primitive cell types, blood cells really arise from mesoderm, which is the origin of connective tissue. And all these cells, all our blood cells, are suspended in fluid, which we refer to as plasma. And that plasma is considered to be the extracellular matrix of blood. So kind of interesting that blood is actually derived from mesoderm, which gives origin to all connective tissue. Muscle contains the proteins, which we refer to as the myofilaments. There are a number of different myofilaments, and these myofilaments are able to work together and contract. And these myofilaments, when they contract, they shorten the muscle cells, and this is what allows movement. 3 different types of muscle: skeletal muscle, cardiac muscle, and smooth muscle. A lot of similarities, a lot of differences. We will be looking at pathologies of skeletal, cardiac, and smooth muscle in a fair amount of detail throughout this course. And then my favorite cells, neurons. These are the cells which primarily make up the central and the peripheral nervous system. We will clearly get into some great detail regarding neurons when we get into neurology and even cardiology when we talk about the electrical conducting system of the heart. One thing that we should understand about neurons is they are the only cells which initiate, integrate, and conduct electrical impulses. And again, we will be looking at that in some detail as we move on through this course. So the human body contains numbers of different specialized tissues and numbers of different specialized cells. And all these cells originate from stem cells, and all these stem cells go all the way back to us being a single cell embryo. That single cell embryo and different stem cells of the body all contain the DNA required to allow that cell to divide, mature, and differentiate into a specific cell type. And we're not going to go through that whole process of mitosis or anything like that again, but I want you to understand that for a cell to get to the point where it's mature and doing its function, certain critical genes and DNA need to be activated. And it's the activation of those genes and DNA which allow the cell to reach the state which it is destined to become. Cells can be dividing. They're actively in mitosis, and M, G1, S, and G2 are the different stages of mitosis. Or cells can be in a resting state, G sub 0, and in that resting state is where they're actually functioning, where they're doing their job. And what is it that makes a cell go through the varying levels of mitosis or into the resting state? Let's take a look at that in a second. We refer to those as growth factors, and there's a number of different types of growth factors that can influence a cell. One type of product which controls mitosis and differentiation are a group of proteins referred to as the cyclins. And the cyclins activate a cell to move into a different stage of DNA copying. And again, if that cell wants to divide, if that cell wants to mature, it's got to copy DNA. So cyclin proteins are a stimulus to tell that cell, hey, time to split, make more of yourselves, or time to rest and start doing your function. Why are we talking about that? Because right now, more and more is being understood about these cyclin pathways and how these cyclins are generated. And more we're starting to target specific diseases by targeting the cyclins. If we have a cancer cell which is growing uncontrollably and we want to stop the proliferation of that cancer, we can take drugs now which target some of these cyclin pathways. And one of the most important cyclin pathway is this one here called the EGF pathway, the epithelial growth factor pathway. And as you can see, it's fairly complex. Growth factors bind onto the cell and stimulate the cell to create a number of different products inside the cell that are going to go bind onto DNA and start activating those critical genes on DNA, which are going to get that cell to divide and start doing whatever function it is. If we have a bunch of cancer cells dividing, and those cancer cells are dependent on that EGF pathway for division, then we can target the EGF pathway, shut it down, and therefore stop that unregulated division of the cell. As we talk more about cancer here in a minute or two, you're going to see that cancer is really unregulated cell division. And that cell division is dependent on a number of these different pathways generating cyclins to turn on DNA. So if we shut off the pathway, don't make the cyclins, cells don't divide, and we have a potential means of managing that individual's cancer. So as we move through this course, we're going to be looking at all these different types of cells, and here we have a number of different cell types on the slide. So as we start in the upper left and move towards the right and down, we are looking at epithelial cells in the kidney. We are looking at bone cells in spongy bone. We are looking at epithelial cells in the colon. We are looking at both epithelial and reproductive cells in the ovary. We're looking at a neuron innervating muscle cells. We're looking at a large white blood cell surrounded by numbers of red blood cells and a small purple platelet. We're looking at endocrine cells in the pancreas and epithelial cells in the pancreas, and then we're looking at epithelial cells and skin. And again, how do we get all these specialized cells? It happens through a process of growth, differentiation, and division. And those processes need to be tightly regulated. And it's those growth factors and hormones and cyclin proteins which do that regulation. Another important part of the cell cycle is eventually they die. Cells are programmed or destined for death, and we refer to that programmed cell death as apoptosis. And in many cancer cells, that apoptotic process has been inhibited, meaning they don't die. They just keep growing and they keep proliferating. And that's not a good thing because we want cancer cells to die. So again, another thing that we can do to target cancer cell is to get them stimulated towards apoptosis and eventually die off. All right, I mentioned this already. We're going to be looking at gross histologic and molecular anatomy and pathophysiology. Again, remember, gross is something that we see by the naked eye. We can see that by physical exam. We can see that in imaging studies. We can look at a surgical specimen. We can look at an autopsy and look at that pathology. Histologic refers to microscopic examination of the tissue and the cell types. Usually a biopsy is obtained of the tissue, and then that biopsy is prepared so it can be looked at under the microscope. And then molecular pathophysiology is looking at those pathways in the biochemistry leading to that pathology. So look right there in the middle of the slide. You see a diagram of a slide, and you see all these different pathways interacting with each other. Remember, EGFR was just one of a number of different pathways which is affecting the genes of that cell and telling that cell to either divide, differentiate, mature, function, or die. Remember, apoptosis. We can also tell the cell to die. So at a molecular level, we're going to look a little bit at some of these pathologies, and we're going to look a little bit at a molecular level where some of these drugs, particularly some of these newer therapies, have their effect. Now, something that you can do, this should be relatively easy. Look at each slide, look at each picture on this slide, and label each one as either being gross, histologic, or molecular. That should be fairly easy to do. All right, let's get into some terms and definitions that we need to know. I'm not going to read through all this just to save time, but I want you to understand the definitions of idiopathic, meaning we don't know what's the cause, right? A lot of disease is classified as idiopathic. We know you have this disease, but we don't know why. Many individuals have a seizure disorder, and you have no idea why they're having seizures. And that might then be considered to be an idiopathic seizure disorder. Iatrogenic is a disease caused by air or a complication. Usually we in the healthcare profession cause that air, led to the individual suffering some pathology. Nice example would be an iatrogenic urinary tract infection because of a non-sterile placement of a Foley catheter. Predisposing, we identify risk factors which increases the individual's likelihood of developing that pathology. In Unit 5, we're going to talk about diabetes mellitus, and we're going to talk about all those risk factors that lead to an increased risk of adults developing type 2 diabetes mellitus. Preventable. The etiology has known predisposing factors, and we can either eliminate or alter those factors. And by eliminating or altering those factors, we can minimize the chance of that individual developing the disease. And then another term that we're going to use a lot is the term lesion, and lesion is a non-specific term which localizes the pathology. That lesion can be gross, histologic, it can be molecular, but the lesion is that thing that we're assigning the cause of the disease to. Some more definitions. Take a look at atrophy. The cell size is shrinking within tissue. Hypertrophy. The cell size is increasing in tissue. Hyperplasia. The cell size, not the cell size is not affected, but the number of cells are increasing. Metaplasia. One type of cell replaces another, and the key here is that it's a mature type of cell replacing another mature cell type. Anaplasia. The cells have become undifferentiated, and this is the basis of cancer, and we'll define this in more detail. Other lesions that we're going to talk about are tumors. Tumors are gross. They are clumps of cells. Tumors can be benign, meaning that they're not cancer. And tumors can be benign, meaning that they are not, tumors can be benign, meaning that they're not cancer, or tumors can be malignant, meaning that they're cancerous. So hold on for a second. We're going to further define that. And then again, apoptosis, important, programmed cell death. Here's some examples of atrophy. Any type of tissue can degenerate or waste. A lot of different things can lead to atrophy. The effect of toxins on tissues. Take a look at that MRI of the brain at the top. That's the effect of chronic alcohol abuse on the brain, is atrophy of the cerebral cortex and dilation of the ventricles and dilation of the subarachnoid space. Lack of use can lead to atrophy. If you ever had a cast on for a long period of time, you know what your muscle looks like on the affected side, so disuse atrophy. Vascular insufficiency, when tissue loses blood supply, will atrophy. So you see two kidneys there. The smaller kidney has atrophied due to maybe renal artery stenosis or something that led to impaired supply of blood to that organ. Lack of nutrition leads to atrophy. Good example is the woman suffering from anorexia nervosa. And a lack of blood supply can lead to atrophy of tissue, and a lack of nervous system innervation can also lead to atrophy of tissue. And you see this in individuals who have damaged nerves, spinal cord patients, individuals who've damaged peripheral nerves. We see that muscle atrophy away. So a lot of different causes of atrophy. Hypertrophy is increase in cell size. Sometimes that's okay. So individuals who are lifting weights and gaining muscle, that's a muscle hypertrophy. That's okay. We would consider that acquired hypertrophy. The individual is doing something to get to that state. Sometimes growth of inner organs is not good. So look at the two examples of the heart in the upper left hand. On the right side is a normal heart. On the left side is a heart with exaggerated, increased cardiac muscle hypertrophy. And that over time can lead to dysfunction of the heart or heart failure. What we're actually looking at there is hypertrophic cardiomyopathy, and we're going to talk about more about that in the cardiac section. We can see glands hypertrophy due to allergy. Glands can hypertrophy due to a number of different types of factors. If you had an allergy and your nose swell up, your nasal turbinates are swelling due to the inflammation being induced by the allergens. Certain men over time will develop glandular hypertrophy, so breast tissue will increase. Technical term for that is male gynecomastia. We'll talk more about that when we get into the endocrine section. So again, these are all examples of hypertrophy where in one case, muscle hypertrophy due to exercise is good, but hypertrophy in these other states are actually pathologic. Hyperplasia is growth of tissue due to increase in the cell number. So the cells themselves aren't necessarily expanding in size, but we're getting more of the cell. And here we see a number of different examples of hyperplasia. Let me point to two of them that we'll talk about in more detail. Thyroid hyperplasia leading to Graves' disease and hyperthyroidism. We'll see that in the endocrine unit. And then prostate hyperplasia, or BPH, benign prostatic hyperplasia, which we see in middle-aged and elderly adult males. We'll also talk about that more as we get into the genital urinary section on pathology. So hyperplasia. And again, there are some times where hyperplasia is a good thing. So a woman who is having her uterus increase in size, part of that process is hyperplasia. That uterus has to grow to accommodate the growing intrauterine fetus, and that's not going to happen without some hyperplasia as well as hypertrophy going on. And in some instances, we see both a combination of both hyperplasia and hypertrophy happening within tissue. Metaplasia, this one's a little bit different. This is where one cell type, one normal mature cell type, is replaced by a different type of cell, and the cell that's doing the replacement is also a healthy, mature, normal cell type. So this is not cancerous, but this can be a precancerous lesion. Again, using that term lesion defining to the area of abnormality. So a nice example of metaplasia is something called Barrett's esophagus. Our esophagus is typically lined by squamous epithelium. If that squamous epithelium starts to be replaced by glandular epithelium of the stomach, that area is referred to as Barrett's esophagus. And we get into the GI unit, we'll talk more about exactly what is Barrett's esophagus or Barrett's esophagitis. It is a precancerous lesion. The lesion itself, Barrett's esophagus, is not cancerous, but those glandular cells which have overtaken the squamous cells can become malignant or can become cancerous. So we refer to that as a precancerous type lesion. And now anaplasia. And anaplasia is always abnormal. It is referring to abnormal changes in the size, shape, orientation, and polarity of the cell and of the tissue. So we look at all these different types of tissue and we see all this tissue, what it looks like normally. We can talk about the architecture of that tissue or the architecture of that organ. In anaplasia, as these cells become abnormal, the architecture of that organ is altered. So here's a biopsy of the uterine cervix. And as you look on the very far left of that biopsy, we're looking at the epithelial cells of the cervix. We're looking at the normal architecture. As we move towards the middle and then into the right, look how those cells markedly change. They've lost their architecture. They don't have uniform sizes and shapes. They don't maintain their orientation. They don't maintain that apical and luminal polarity. And when that happens, we can use this term anaplasia. And as we'll see in a second here, anaplasia is one of the three main properties of cancer. So essentially what we're looking at here is we're looking at a biopsy of the uterine cervix where one part of that biopsy is normal based on the histologic architecture, but the other side is malignant or cancerous due to the high amount of anaplasia, which is being manifested in this microscopic section. All right, so we mentioned this already. Cancer is a disease caused by the abnormal differentiation of abnormal cells. Remember, normal cells will grow and divide and differentiate. Cancer cells are abnormal cells which have lost all those regulatory pathways, and not only are they abnormal cells, but they are abnormally dividing. Remember, when we have a clump of cells growing together, we can refer to that as a tumor. Normal cells, which are clumped and growing together as one mass, we refer to as a benign tumor. So you can have, we'll see this more when we talk about skin next week. There's a lot of benign tumors of skin. It's a clump of cells growing together, making a freckle or making a mole, but those cells are all normal, therefore it's not cancer. We consider that to be benign. But if we have a tumor where all the cells are abnormal and the cells are growing abnormally, then refer to that as malignancy or cancer. And any cell type in the human body can become unregulated and become malignant. As we have numbers of different cell types in the human body, we have numbers of different types of cancer. And I think everybody already understands that. When we talk about cancer, we're just not talking about one entity, but we're literally talking about dozens and dozens of different types of unique and specific pathologies that all fall into that big group that we call cancer. At the root of cancer is alterations in DNA, specifically the genes which code for the proteins that control cell growth and cell division. If that DNA becomes mutated, and those proteins now become dysfunctional, meaning that they're no longer regulated and they're constantly in effect, that can lead to abnormal growth, abnormal division, which equals anaplasia, which eventually leads to the malignant tumor. So, important point, at the root of all cancer is the alteration of that DNA, which is coding for those proteins, which is necessary for normal growth and cell division. Cancer, again, abnormal division of abnormal cells. So here's a couple examples. Take a look at the normal histology on the left, and then look at the malignant abnormal histology of cancer on the right. So I show you a nice example of normal bone histology and then bone cancer, normal bladder histology and then bladder cancer. And again, I'm not going to put any type of slide on a quiz and put that up and say, tell me what type of cancer it is. But if I showed you two pictures, one being the normal architecture and then the other being the abnormal architecture, you should be able to look at that and say, hey, something doesn't look right. Look at those cells. They just are, they're not aligned properly. They seem to have lost their orientation. Their sizes are different. That's all part of anaplasia. Again, pathologists looking at that and saying, hey, that organ, that tissue no longer looks like it's supposed to look like. So remember, normal cells grow, differentiate, they function, reproduce, they get replaced, and eventually they die. That's all a tightly regulated process. In cancer, that growth and differentiation is gone. The cells no longer look like they're supposed to look, they no longer act like they're supposed to act, and they grow and reproduce without control. And this is what we're talking about. We're talking about anaplasia. It's the loss of that normal architecture. And here's a couple of nice microscopic photos showing you example of both bone cancer and bladder cancer coupled to the normal architecture. So again, we said that at the root of cancer are DNA mutations, which lead to that abnormal growth and differentiation. So let's introduce a new term. Let's introduce this term called an oncogene. An oncogene is a type of DNA mutation that leads to a dysfunctional protein which produces this abnormal growth and regulation. And it is the oncogenes which are the root of cancer. The presence of oncogenes raises the likelihood of one developing cancer. So within a tumor cell, we're destined to find these DNA mutations. We're destined to find these oncogenes. Typically, it starts as one oncogene, but within a tumor, we may find many different segments of mutated DNA or many different types of oncogenes. So in our little picture here on the right, let's imagine that we've got a lining of epithelial cells, and suddenly one of those epithelial cells mutate. That mutation leads to abnormal differentiation and proliferation of the cells. So now, rather than having one cell, we've got a number of mutated cells. As those mutated cells continue to grow and replicate, more mutations with DNA are induced, and by the time we get to the tumor, you can see that we've got, at least in the photo here, we're showing 3 different types of abnormal cells: white cells, yellow cells, and red cells, and the color is supposed to represent different mutations. All right, so I think it's a nice graphic to make that point. A malignancy or a malignant tumor is going to begin with an oncogene. As that DNA gets rapidly copied and copied via processes which are not being regulated, more mutations are going to ensue. So therefore, within that malignant tumor, within that cancerous tumor, we're going to have a number of different DNA mutations or a number of different oncogenes. Now, oncogenes can happen spontaneously. Oncogenes can occur due to genetics, mean that we got an oncogene from mom or dad, or oncogenes can develop due to certain carcinogenic behaviors which mutate DNA. So think about that for a second. Think about what types of behaviors can an individual do that will lead to a mutation in DNA which gives them an increased risk of cancer. You should be able to come up with a number of different carcinogenic behaviors. All right, so again, more on oncogenes. Oncogenes are those specific mutations of DNA which lead to abnormalities in growth and regulation, and therefore can lead to cancer. Having an oncogene doesn't mean you're going to develop cancer, but having an oncogene can increase your risk of cancer. And these oncogenes can happen due to hereditary. We got them from mom and dad. They can happen spontaneously, or they can happen due to carcinogenic behavior, something done to the human body that adversely affected DNA and mutated the DNA. And here's a list of some known oncogenes and the different types of cancers which are associated with that oncogene. And again, this is for your information only. I would never give you a quiz question that says, okay, tell me what types of cancers are associated with the LMIC, the LMIC oncogene. If you look, you can see that a certain type of lung cancer is associated with LMIC. So this is really interesting stuff, and this is kind of making up the whole basis of individualized cancer care now, is what DNA is present in that tumor, and can we target some of that specificity of that tumor based on the DNA being found within the tumor. Very, very interesting stuff, and we'll get a little bit more into that in terms of some of the chemotherapy as we move on here. All right, here's our celebrity guest of the week. Here's some questions to think about. Who is she? What did she find out about her medical history? What did she do about it? And if you were to have a patient who had what Angeline found out in her medical history with respect to the BRCA mutation, the BRCA oncogene, what did that place her at risk for, and what did she decide to do about it? Very, very interesting stuff as we start screening individuals more and more and finding out what's in their DNA and what might they potentially be at increased risk for based on your DNA makeup. And in the specific case of Angelina Jolie here, the BRCA mutation leading to her increased risk of breast cancer. All right, let's start to define some cancers. Please take a look at these 2 pages in the text to clarify a little bit more. If we have a cancer of connective tissue origin, we refer to that as a sarcoma. Remember, go all the way back to embryology. We have ectoderm, mesoderm, and endoderm, and those 3 primitive cell lines become the mature cell lines. And a lot of these cancers are differentiated and labeled based on the cell line which they arose from. So if the individual's cancer is a cancer of connective tissue, then refer to that as a sarcoma. Bone is connective tissue. Osteo refers to bone, so osteosarcoma is a specific type of bone cancer. There's numbers of different types of bone cancers. Osteosarcoma is one specific type. But when you see that term osteosarcoma, that should hit you in the head right away. You say osteosarcoma. Oh, sarcoma means cancer of connective tissue. Osteo refers to bone, so osteosarcoma has to be a malignancy of bone. Carcinoma refers to cancer of epithelial origin. And remember, the epithelial cells are the cells that do the outer and the inner lining of organs. These are the most common types of cancers. So cancers that arise from epithelial cells are referred to as carcinomas. So if you had a skin cancer that came from epithelial cells of skin, we would call that a squamous cell carcinoma. If you had a cancer that came from endodermal cells, and the endodermal cells are typically the glandular epithelial cells, then we add adeno in front of it, so adenocarcinoma is a glandular epithelial cancer. And if we say adenocarcinoma of the bladder, that means that that cancer of the bladder came from glandular epithelium. How do we know that it came from glandular epithelium? Because it's been labeled adenocarcinoma, glandular epithelium. And again, it's the microscopic analysis, it's the pathologic analysis of the histology that's going to make that diagnosis. A lot of different classifications of tumor. These ones that are up here, I definitely want you to know the terms for these. Take a look at table 12-2. It'll help you out with some of those terms as well. Be careful with some. An adenoma. So an adenoma is a benign tumor derived from glandular cells. An adenoma means it's not cancer. An adenocarcinoma is a glandular cancer, okay? And we know that it's malignant because we've attached carcinoma to it. So take a look at some of these terms. And as we move on into the various units, we'll talk more specifically. So melanoma, when we get into the skin unit, lymphoma, when we get into the hematology unit, leukemia, when we get into the hematology unit. So again, just kind of introducing some of this terminology to you in this unit, more specifically as we move into further units. All right, again, here we are, epithelial cells, re-emphasizing for you some of the normal characteristics of epithelial cells. Two things that I want to bring up about epithelial cells, as they are highly mitotic. They are always going through stages of growth and division. The key there being regulated growth and division. And the epithelial cells tend to have the highest contact with carcinogens. So you take these cells that are already rapidly dividing and you expose them to the highest concentrations of carcinogens, you can see why epithelial cells are the most common cell lines which develop into cancer. So again, here's epithelial cells of the uterine cervix, epithelial cells of the colon, epithelial cells of the skin, and they all have that nice, distinct, normal architecture, normal cellular polarity. When they lose that architecture, when they lose polarity, when those cells become anaplastic due to unregulated growth and division, then we can refer to that as being cancer. And again, epithelial cells are the most common cell line which can develop into cancer. All right, here's another term, carcinoma in situ. So remember, carcinoma refers to an epithelial cell cancer, right? In situ means that the malignant cells are confined in the epithelial layer. So remember, one characteristic of the epithelium is those cells are confined above a basement membrane, meaning the cells do not bust out of the layer. They don't bust through the basement membrane and into deeper tissue. If you have cancerous cells of the epithelium, but they are all contained above the basement membrane, then we refer to that as carcinoma in situ. Or another way to think about this, it's a pre-invasive cancer. If those epithelial cells got out of the epithelial layer and got into deeper tissues, we would call that invasive cancer. Carcinoma in situ is a pre-invasive cancer. It's still cancer, still can have some devastating effect. It still might have to be treated. But in general, because carcinoma in situ has not invaded into deeper tissues, it tends to be a type of cancer that has a better prognosis. The deeper the cancer gets, the worse is the prognosis. Carcinoma in situ, confined above the basement membrane, is going to typically have a better prognosis. And we'll see a whole lot more of carcinoma in situ when we talk about skin cancers next week. Take a look at the pictures here. There's normal bladder epithelium. Look how those cells have nice polarity, have nice architecture. A pathologist would look at that and say, yeah, all those epithelial cells are in the epithelial layer. They're not busted through the epithelial membrane. And then you give them a biopsy of adenocarcinoma of the bladder, and they say, yep, all those epithelial cells are highly disarrayed, extremely abnormal, both in their size, in their shape, in their polarity, in their nucleus, in their nuclei. You see the big difference between the two pictures there? That's a nice example of anaplasia. But the other thing the pathologist will say here is, hey, but all those malignant cells have not gotten into the deeper layers. They're only in the epithelial layer. So I would call that adenocarcinoma of the bladder in situ. Okay? Pre-invasive cancer. Again, anaplasia, defining anaplasia, loss of the normal architecture, loss of the morphology. The cells are distorted in terms of how they're oriented, how they're shaped, how they divide, what does their nuclei look like, what their nucleoli look like, how they stack up on each other. And another thing that happens is they lose contact adhesion. Remember, epithelial cells have a property called contact adhesion. They like to stick to each other. These malignant epithelial cells kind of lose that contact adhesion, and allows them to kind of go every which way that they can. So again, going back to the cervix, here we can see what normal squamous epithelial cells of the cervix looks like on the left picture. Now take a look at this Pap smear. Can you see both the normal squamous cervical cells and other cells in there that just don't look right? The other cells that just don't look like are the anaplastic malignant cells. And then in the actual biopsy, again, take a look. Now we're going from right to left, where the right side shows you the normal cervical epithelium, and as you move to the left, look how that layer starts showing you all that loss of architecture or anaplasia. So again, one of the primary properties of cancer is anaplasia, and that's shown very nicely here in the cellular and biopsy, in the cellular Pap smear, and in the cervical biopsy, showing you anaplasia of the cervix. Nice pictures there. Okay, another property of cancer is invasion. So I hinted a little bit about this with respect to in situ. If you take a malignancy and you begin it in one layer of tissue, and now those cells bust into the adjacent tissue, we'll refer to that as invasion. So another property of cancer is those anaplastic cells like to get out of their tissue of origin and get into adjacent tissue, invade into the adjacent tissue. And in the graphic here, in the cartoon, you see the normal cells, and then you see the anaplastic cells, and you can see that anaplastic cells busting out of its layer, whatever that layer might be, and into the adjacent layer. So that's invasion. Now take a look at the two biopsies. Let's look at the cervix first. See the normal cervix on the left, and then see all that highly abnormal pathology on the right, and look at how all that pathology has kind of busted out of the epithelium and into the deeper tissue of the uterus. That biopsy there is showing you both anaplasia and invasion. Can we call that cervical cancer in situ? What do you think? You're right. The answer is no. You can't call it in situ anymore because that cancer has now busted out of the epithelial layer and it's in the deeper layers of the cervix. Now take a look at the colon. Look at the left side and you can see the normal epithelial architecture of the colon. And now in this biopsy site, look at that highly abnormal anaplastic tumor on the right, and you can see that that tumor has deeply invaded into other areas of the colon. So again, that colon cancer there is showing you both anaplasia and invasion. So far, two properties of cancer, anaplasia and invasion. And here's our third property of cancer, metastasis, meaning that cells have broke off from the primary tumor. Primary refers to the original site where the cancer developed. So cells broke off from the primary tumor and have traveled distantly to other organs. And these cells can travel via the bloodstream. These cells can travel via the lymphatics. If they start in one site and end up in a distant site, then we refer to that as metastatic disease. Well, why do these cells break off and travel? Remember, one of the numbers of things that can happen to malignant cells is loss of contact adhesion. Contact adhesion tends to keep cells where they're supposed to stay located. So as an example, we wouldn't normally expect to find skin cells in our lungs or skin cells in our bone, right? Because the skin cells aren't invading other tissue, or the skin cells aren't breaking away and metastasizing to other tissue. But malignant skin cells, on the other hand, anaplastic malignant skin cells, which have lost regulation, have lost differentiation, have lost polarity, have lost contact adhesion, now they're able to break away, get into the bloodstream, travel to distant sites, get into lymphatics, travel to distant sites, or just outright invade and burrow into surrounding tissue. So our three properties of cancer now are anaplasia, invasion, and metastasis. And we've got a couple of pictures of CT scans for you. One shows a tumor in the brain. So if that individual had a primary malignancy of breast, and that malignancy spread to the brain, we would call that metastatic breast cancer of the brain. In the other slide, we're looking at the liver. So the liver is the big organ that you see on the left. And then look at that darker area of the liver. That's a tumor. So if that was found to be same thing, if same individual, if those breast cancer cells metastasized and got to the liver, then that would be referred to as metastatic breast cancer of the liver. Okay? So the primary tumor in this case would be the breast cancer, whatever that might be, and there's numbers of different types. Eventually we'll get to those different types. But you see what I'm saying? The primary tumor started in breast, and then it metastasized to different organs. So we refer to that then as metastatic breast cancer of the brain because it involved the brain, metastatic breast cancer of the liver because it involved the liver. So malignant cancerous tumors show anaplasia. They lack regulation of the cell, regulation with respect to differentiation and growth. They lack contact adhesion. They can show invasion, and they can metastasize. Right in the middle of the slide there is something called angiogenesis. Read page 381 in the text just to see a little bit more about angiogenesis. Angiogenesis means that in a growing cancer, blood vessels can grow into that tumor and essentially feed the tumor. So again, think of living cells. Cancer is a clump of malignant living cells, and that clump of malignant living cells requires oxygen and nutrients to keep dividing and proliferating. So certain cancers will secrete certain growth factors that will allow blood vessels to begin dividing and growing into that tumor. That's referred to as angiogenesis, and that keeps the tumor alive. This is important because now a newer means of treating some of these cancers is not so much to attack the cancer cell, but to attack the blood vessels going into the tumor. And if you can kill the vasculature going into the tumor, if you can stop that tumor from developing vasculature, the tumor will die because it's not getting oxygen and it's not getting nutrients. So we'll take a look at that at some point in this course. We'll talk a little bit more about chemotherapy, which is targeting angiogenesis, trying to stop that vascular growth into the tumor. All right, here we are again. Anaplasia, invasion, and metastasis, showing you examples of each. Remember that at the root of cancer are mutations in DNA that we refer to as oncogenes. We can get these oncogenes genetically, meaning that we've inherited them. Certain individuals and certain races and ethnicities have a higher risk of having a certain type of genetic disorder versus others, meaning that certain races and ethnicities will have higher risk of carrying certain oncogenes versus another. And then we can certainly acquire oncogenes later in life just through the aging process. DNA mutates. So cancer is more common in individuals over the age of 50 and certainly over the age of 65. And that's just part of the aging process where DNA is normally, I guess we shouldn't say normally, but DNA is mutating, placing us at greater risk of cancer as we age. But then again, other acquired behaviors that we do, other carcinogenic risk factors that we do can also mutate DNA. So a couple of slides ago, I asked you to think about behaviors that can lead to acquired oncogenes or carcinogenic behaviors. And I hope you all said smoking, right? We know that smoking increases the risk of cancer, excessive alcohol consumption, eating too much processed red meat, right? How about staying out in the sun for a long period of time without sunblock, right? You can come up with a lot of different things that have been deemed to be carcinogenic risk factors, right? Because it's leading to mutations in DNA, which is leading to an increased risk of one developing cancer. All right. So a couple things that you should be able to do on the upcoming quiz. If I give you a risk factor, you should be able to tell me if that risk factor was either genetically given to the person or acquired through behavior. If I show you a photo of cancer, you should be able to tell me if that photo is showing any combination of anaplasia, invasion, or metastasis. I think that should be relatively easy to do. Here's some more views of cancer, both histologic and gross. So we're looking at malignant melanoma. Look on the left-hand side. We're going to talk more about skin and melanocytes, but melanocytes in skin, melanocytes within the epithelial layer of skin is what gives us complexion, gives us freckling, right? That's healthy. Those are normal melanocytes. But melanocytes can become malignant, and they can then show anaplasia, they can show invasion, they can show metastasis. So look at these different pictures of malignant melanoma on the right in terms of what a primary tumor might look like on skin and what melanoma might look like as it metastasizes to a lymph node, as it metastasizes to the brain, what it might look like under the microscope, showing you its invasion out of the epithelium and into the deeper structures of skin. So again, showing you all those properties, anaplasia, invasion, and metastasis. And trust me, we will talk a whole lot more detail about malignant melanoma next week. I'm just using these pictures right now as examples of some of these general properties that we are talking about in this unit. I would imagine that most people understand the 10 warning signs of cancer, right? You've seen this over and over. Go ahead and look at this again. This is important stuff to understand, particularly as you are developing yourselves into diagnostic clinicians, looking at an individual in terms of their historical complaints, in terms of their physical exam complaints, and coming up with, that, geez, this might be cancer, right? Not every complaint that somebody walks into the clinician's office with is cancer, right? If I came into your office as a 58-year-old male and say, geez, over the last 2 days I've had a fever, and my throat really hurts, I have a hard time swallowing, you look at my throat and you see it looks red and got some pus on it, you probably wouldn't think cancer right away, right? But if I came into you as a 58-year-old male and I said, geez, it's been more and more progressively difficult for me to swallow, it's starting to hurt when I swallow, even when I'm swallowing liquids now it hurts, coughed up blood the other day, you might say, ooh, something doesn't sound right there and I better start thinking of something more serious with you. So that's what the whole know the 10 warning signs of cancer. So as we're doing some introduction to malignancy right now, important for you to understand these warning signs, and then coming into this next slide here, you should be able to take a look at these really brief clinical scenarios and say, yeah, that sounds like that might be a risk for having cancer. So I'm not going to read through all these, but I definitely want you to read through these 8 little vignettes, and then based on what you know about the warning signs of cancer, say to yourself, might this be a malignancy causing the problem, or do you think it's something more benign, an acute infection or whatever? So again, important to understand those warning signs, and this is just a really quick way to refresh yourselves of that. All right, now really quickly, here's a tumor, right? So our blue cells are the anaplastic cells. They no longer look like the normal pink epithelial cells. This is a biopsy, it came from any organ where we're looking at the epithelium. So the pink side is abnormal, the blue side is abnormal. Pink side normal, blue abnormal, right? And you can see anaplasia in there in terms of their stacking, different sizes, right? No longer look like. If this were epithelial cancer, could we call that cancer in situ based on this picture? You're right, we couldn't. And the reason that we couldn't is because those cells have broken through. So that kind of like orangish brown membrane, that's the basement membrane. Remember, the epithelium. Epithelial cells do not break through the basement membrane. These malignant cells have broken through the membrane, so it's no longer in situ. We now have an invasive cancer, right? Worse prognosis if it's invaded versus in situ. All right, that's a quick review regarding the picture, but now let's just quickly talk about how can we stop cancer cells from dividing. So let's just really quickly here, let's look at chemotherapy. Chemotherapy can come in 2 different flavors, if you will. It could be non-specific or it can be targeted. Remember, cancer is rapidly dividing cells. So a non-specific chemotherapy would kill any rapidly dividing cell, and we have numbers of rapidly dividing cells in our body, right? So if we give somebody an agent that kills the cancer cell, but also kills normal cells, we would consider that to be non-specific. And we can also have targeted chemotherapy, meaning that there's something unique about the cancer cell present on the cancer cell that we can hit and kill that cell, and that target on the cancer cell is not found on other normal cells. Therefore, the chemotherapeutic drug leaves the other normal cells alone. And that's the preferential way of treating cancer. It used to be that there was no such thing as targeted chemotherapy. Everything was non-specific. And the further and further we go into cancer research here, we can see scores and scores of targeted chemotherapy drugs being released. And again, as we get into some of the specific cancers in each unit, we'll look briefly at some of this targeted chemotherapy. A key part of a cell being able to divide, whether that cell is normal or whether that cell is cancerous, if that cell wants to divide, it has to copy DNA. So if you can stop the cell from copying DNA, if you can stop the cell from going through mitosis, you can stop the proliferation of the cancer. So a lot of the non-specific chemotherapy targets DNA, and a lot of the non-specific chemotherapy targets mitotic processes. What do I mean? Let's take a look here at some non-specific chemotherapy drugs. And for those of you that are working in oncology, you have seen all of these drugs: oxaliplatin, doxorubicin, cytarabine, irinotecan, paclitaxel. These are some of the more commonly used, some of the more important non-specific chemotherapy weapons or drugs that we have. And look at what these things are doing. Oxaliplatin binds to DNA When it binds to DNA, it renders that DNA inactive of being copied. Doxorubicin binds to DNA by different mechanisms and damages the DNA so it can't be copied. Cytarabine inhibits the synthesis of DNA, so if you can't make DNA, you can't copy it. Irinotecan inhibits the uncoiling of DNA through an enzyme called topoisomerase. So irinotecan is known as a topoisomerase inhibitor. If you remember the general structure of DNA, it's a twisted double helix. Well, to copy that DNA, you have to uncoil it, you have to open it up. If you can't uncoil it, if you can't open it up, you can't copy it. And if you can't copy it, the cell can't proliferate. So that's another way of getting at inhibiting a cancer cell from dividing, is block that enzyme called topoisomerase, and that's what drugs like irinotecan do. And then paclitaxel, another non-specific chemotherapy agent. Paclitaxel has no effect directly on the DNA, such as the other four, but what paclitaxel does is it inhibits the proliferation of the mitotic spinules. Spindules. What the hell is a spinule? Spindle, sorry, inhibits the mitotic spindles or tubules. Remember, at the end of mitosis, you're going to take half of the DNA and pull it to one side and half of the DNA and pull it to the other side, so the cell can then break into two distinct cells, each with its own copy of DNA. The mitotic tubules attach to those DNA, attach to those chromosomes, and pull it apart. So if you block the ability of those tubules to be functional, then cell can't divide. Cell can't divide, you got a way of controlling cancer. So this is what nonspecific chemotherapy is all about. It's doing something to inhibit the cell from dividing. And most common mechanisms that do that is by damaging the DNA or doing something to keep the DNA from dividing, or just keeping the cell from splitting by affecting it in mitosis. Then again, if you are in oncology, you have seen a number of these drugs. And again, a lot of different nonspecific drugs that are out there. These are just 5 of the more commonly used, and at least each one representing a different mechanism. Now, the damaging thing about these types of nonspecific chemotherapy is they're not specific for cancer. They get the rapidly dividing cells, so other rapidly dividing cells can be killed due to giving this type of chemotherapy. And again, you've seen this, so if you're in oncology or if you're taking care of cancer patients at any degree, you see what are the complications of some of this non-specific chemotherapy. So the advantage is that these drugs are very effective killers. They're really good at killing rapidly dividing cells. The only problem is they're killing all types of rapidly dividing cells other than the cancer cells. That's the big disadvantage then, right? They're getting our normal cells, not only our dividing cells, but they also have the ability to kill resting cells. They're extremely toxic. You guys know that, those of you that are administering this type of chemotherapy know that it requires proper handling. Pharmacists putting this chemotherapy together require proper handling as well. It's hazardous stuff, right? I know that our hospital, we have something called Code Orange. If one of these highly toxic chemotherapeutics were to be spilled on the floor or whatever, you call it Code Orange. You got to treat that as hazardous waste, right? And numerous adverse effects. So here's an individual suffering from some type of cancer, receiving some type of nonspecific chemotherapy, losing hair, thinning skin, developing sores on the mucosa, losing blood cells, becoming anemic, losing white blood cells, becoming lymphopenic and neutropenic, developing adverse GI effects, pain, nausea, vomiting, diarrhea, all adverse consequences of this nonspecific chemotherapy doing doing their mechanism on normal cells. So it'd be great if this nonspecific chemotherapy only got the cancer cells, but those mechanisms don't work that way. That's why they refer to it as nonspecific. That was the end now of cancer, but again, just the end of our introduction to cancer. We've got a lot more to talk about with respect to specific cancers when we get there. Now let's introduce our last unit for this week, and let's talk about inflammation. Now, here's a task for you. These are all inflammatory processes that we're looking at. Think about how you would describe inflammation, and then as we go through to the end of this unit, come back and then re-describe it and see if you would describe inflammation differently. Okay? All right, let's go. Inflammation. Everybody has had an inflammatory process happen to them. Everybody has seen inflammatory processes in their patients. The inflammatory response is fairly complex. We're going to break that down into some simplistic stuff here over the next couple of slides. I would like you to take a look at these two figures on pages 195 and 196 to kind of just quickly review that acute inflammatory process. All inflammation begins with a trigger. Something triggers inflammation. Most of the time it's a foreign invader, such as an infectious organism, an allergen, an inanimate object, bug saliva, right? Something foreign to us usually triggers it. Sometimes an injury can trigger inflammation, damage your cartilage, ligaments, when you twist your ankle. Sometimes the trigger is yourself, meaning that the process of inflammation is beginning because of something which is inherent to us. It's not foreign. So it's we refer to that as autoimmune inflammation. We're going to talk a little bit about autoimmune disorders coming up here in a minute or two. So that trigger is usually referred to, that the term that we give that trigger is the antigen. This is what we're reacting to. And we react to antigens via our white blood cells. When white blood cells begin the process of dealing with the antigen, a number of things are going to happen. Blood vessels dilate. The blood vessels start to become leaky. The first white blood cells involved in the inflammatory process begin to call in more white blood cells. In addition to white blood cells being activated, platelets will also begin to be activated. So this is just like acute inflammation at a very high level. It's vascular, it's white blood cells, and it's platelets. And we're going to talk a little bit deeper in terms of what that means. So now, we talked about this concept of triggers or antigens. Really quickly here, think in your head, name some type of foreign invaders or foreign triggers. Name some type of injuries that one can develop that can lead to acute and chronic inflammation. And then think of some diseases where the inflammatory process is targeting the individual. Think of some autoimmune inflammatory diseases. All right, just like cancer can start in any cell of the human body, inflammation can involve any type of anatomic tissue. So anything in the human body can become inflamed. And we use this suffix itis, meaning inflammation. So if you take your skin and your skin gets inflamed, we can call it dermatitis. If your sinuses get inflamed, sinusitis. If your blood vessels get inflamed, vasculitis, right? So itis implies inflammation. It does not imply infection. While infections are common causes of inflammation, not all inflammatory processes are infectious, right? And you understand that already, right? You know that allergens can cause inflammation. You know that toxins and irritants can cause irritation, right? Take a can of Coppertone SPF 50 sunblock spray and accidentally spray that into your eyes, right? Your eyes are going to get red and inflamed. You're going to have conjunctivitis, but that's not infectious, right? The inflammation is due to the irritation of the chemicals that got sprayed in your eyes, right? And then autoimmune. Again, autoimmune as well is not infectious. It's the inflammation being targeted to a self-antigen or something inherent in the body. All right, so there's some medical terminology. There's a number of different types of itises there. I'm sure you're all familiar with that med terminology, so we don't really need to go through it. Inflammation again. Inflammation is white blood cells, platelets. What activate those white blood cells and platelets are inflammatory mediators. So we're going to get into what is an inflammatory mediator. And then if that inflammatory process persists for a period of time, when it goes from acute to chronic inflammation, then another type of cell becomes involved, and those are the fibroblasts. So we're going to differentiate acute versus chronic inflammation, and we're going to differentiate what are the inflammatory mediators that are activating this process of inflammation. Whether it's acute inflammation, whether it's chronic inflammation, these inflammatory processes can all be damaging to tissue, right? And we know that. We know that any inflammatory process can be damaging to tissue. So just like cancer damages tissue, inflammatory events can also damage tissue. Now, knowing med terminology and knowing to add itis into inflammatory disorders, go back 2 slides, back yourself up 2 slides, look at all those pictures that I said describe inflammation, and then name each picture as an itis, right? So, as an example, you got the hand there where the fingers look red and swollen. You imagine that's painful. That looks like, what term would you use for that? Arthritis, right? So yeah, so go through those pictures and name each of those pictures by its proper inflammatory term. All right, what is this? This looks like another one of these pathways that Dr. Stremski likes to show. Yeah, I do like to show a lot of these pathways. We're going to be looking at a lot of this stuff in this course. So here is an overview of an inflammatory pathway. Now, inflammation is due to the activation of certain cells, primarily white blood cells. We have a lot of different types of white blood cells. We're going to talk about lymphocytes, mast cells, neutrophils, and macrophage. These are some of the primary white blood cells involved in the inflammatory process. Our white blood cells kind of live in a state of being inactive. They're kind of like floating around in blood. Some of them are actually in tissue and fixed in tissue. And they're just kind of hanging out, doing their thing, doing their surveillance. And then when they need to be activated, the process of activating these white blood cells is what starts them to do their job. It starts them to process these antigens and eventually eliminate the underlying trigger, the underlying stimulus, whatever that might be. So how do these cells get activated? They get activated through a series of chemicals called inflammatory mediators. And as we look on this slide here, we see at the top, we see a trigger. And again, that trigger can be a lot of different things. It could be an infectious agent. It can be an allergen. It can be an irritant, whatever. the trigger starts to activate macrophage and mast cells, and then those macrophage and mast cells start to release pre-stored inflammatory mediators, and these pre-stored inflammatory mediators, when they're released, begin to activate more macrophage, more mast cells, and other types of white blood cells, particularly lymphocytes. We have inflammatory mediators that are protein by nature. We have inflammatory mediators that are lipid by nature. So if you look on the left side here, you see things like interleukin, TNF alpha, immunoglobulins. Those are protein inflammatory mediators. And if you look on the right, you see things like leukotrienes, prostaglandins, thromboxanes. Those are lipid inflammatory mediators. So let's talk about the difference as we move on here about what these inflammatory mediators are and what do they do to these white blood cells. So a lot of the inflammatory process begins with the mast cell. A mast cell is usually the first type of cell to respond to the trigger. And mast cells, a specific type of white blood cells, are a cell which can be found in tissue as well as in the bloodstream, and these mast cells are very granular. They have granules within their cytoplasm, and then within that cytoplasm, they're loaded with different chemicals, and these chemicals are referred to as inflammatory mediators. Histamine, serotonin, kinin, prostaglandin, all these different chemicals are inflammatory mediators, and each cell type has a different inflammatory mediator or different combination of inflammatory mediators within the cell. These mediators are typically pre-synthesized and stored and ready to be released upon stimulus of the cell. So mast cells are one of the first cells to respond. And in mast cells, what do you think about this, you may know this, what do you think is the predominant inflammatory mediator found in the granules of a mast cell? You know this? It's histamine. Histamine is a very potent inflammatory mediator, and histamine plays a huge role in inflammation due to allergens and irritants. So histamine is one type of inflammatory mediator. It happens to be the predominant inflammatory mediator in a mast cell. But serotonin and kinins and prostaglandins, other types of inflammatory mediators, TNF alpha, tumor necrosis factor, IL, interleukins, other more complex inflammatory mediators, those are protein inflammatory mediators, a little bit larger, made up of amino acids and peptides versus the smaller molecules like histamine and serotonin. Nonetheless, it's the combination of these mediators that get released into systemic circulation, which are going to activate more white blood cells, more neutrophils, more macrophage, more lymphocytes. And it is the activation of those white blood cells which will maintain and proliferate the inflammatory process. Now, all these pictures on the bottom show you a lot of different triggers, right? Viruses, allergens, trauma, blood products, insects, infectious organisms, wood splinters, bacteria, irritants, spider venom, bee venom, proteins found in vaccines, right? There's a lot of different things that can be put into the human body through a variety of different routes. Ingest it, inhale it, inject it, whatever. They're all triggers, right? And it's these triggers that are going to initiate the inflammatory process. What type of disease is it? If the trigger is a self-antigen, meaning it's not foreign, there you go. It's autoimmune inflammation, right? So the trigger can either be self, Therefore, we get an autoimmune response, or it can be foreign. Most inflammatory processes that we deal with are due to foreign substances like viruses and irritants, etc. All right, what's the role of these inflammatory mediators? So these inflammatory mediators call more white blood cells to the party, if you will. So here's a macrophage. So on the right side of the upper slide is a macrophage. And that macrophage gets exposed to a foreign peptide. And that macrophage begins to process that foreign peptide or that antigen. And it says, we got to do something about this invader. We got to do something about this foreign invader. So I'm going to activate this lymphocyte. And by activating this lymphocyte, that lymphocyte's going to activate more lymphocytes and bring more of these lymphocytes to the party to begin the inflammatory process. Okay? So let's take a look at an inflammatory process here. The upper picture here is a normal photo of a pancreas, and the lower picture is a histologic photo of pancreatitis. So now knowing med terminology, right? Pancreatitis means what? Is pancreatitis cancer of the pancreas, or is it something else? Pancreatitis is inflammation of the pancreas, right? So now we have an inflammatory process going on in the pancreas. And look at how histologically it's different from the normal pancreas. Now, again, I'm not trying to make pathologists out of anyone in this class, and I'm never going to give you a slide where I'm going to ask you to interpret microscopic pathology, but I think it's good to take a look at this stuff and try to understand it. What we're seeing in the photo of pancreatitis is that the tissue looks abnormal, right? You can still see some resemblance of some of that pancreas in there. It's tough to see, but it's there. But you see a lot of these other cells have gotten in there, and a pathologist would look at this and would be able to say, yeah, that's all normal lymphocytic infiltration. That's not cancer cells infiltrating in there. It's lymphocytic cells in there. And the other thing that I see in there are these red spots, and these red areas are red blood cells. So there's some hemorrhage going on in here. There's some increased blood supply coming on. And to me, as a pathologist, that tissue kind of looks swollen. So what do we see in an acute inflammatory process? We see swelling, we see increased vascularization and hemorrhage, and we see a proliferation of white blood cells. This is the acute inflammatory process, and that acute inflammatory process is brought on by inflammatory mediators activating white blood cells to induce this effect. We're going to talk about something called JAK-STAT. JAK-STAT is a specific type of receptor enzyme complex that we find in white blood cells. And activation of that JAK-STAT complex is one way of turning on these white blood cells. We'll talk about anti-inflammatory drugs in a minute or two here, and we're going to see that some of those anti-inflammatory drugs affect JAK-STAT. Some crazy terminology, but just think of it. Hey, I got to activate white blood cells to begin an inflammatory process. I can do that for a number of ways. One important way to activate those white blood cells is through something called the JAK-STAT pathway. All right, so now what I've done, now I've taken that slide that you saw already that shows the trigger and shows these array of different inflammatory mediators, and now what I've done in purple is I've added in the names of a bunch of drugs. And all of these drugs that are on there are drugs that can stop an inflammatory process, can minimize inflammation. Antihistamines like diphenhydramine and cetirizine neutralize histamine. Steroids like prednisone, fluticasone, clobetasone neutralize that enzyme phospholipase, so we can't make leukotrienes and prostaglandins and thromboxanes. Non-steroidal anti-inflammatory drugs like aspirin and ibuprofen neutralize an enzyme called cyclooxygenase, so we can't make prostaglandins. Montelukast or Singulair neutralizes leukotrienes, an important inflammatory mediators in the respiratory tract. And then when we move over to the left side of the slide, we see some of the newer drugs like Humira, adalimumab, tofacitinib, Xeljanz. They are neutralizing some of the proteins involved in that JAK-STAT pathway. Hold on to that for a second. We'll look at that in a little bit more detail in a minute here. And then we also know that we can, if inflammation is due to activation of white blood cells, we can use some drugs to kill the white blood cell, right? So look at drugs like, for those of you that are in oncology, you know that 6-MP, 6-mercaptopurine, and methotrexate are drugs that are used for treating certain types of cancers. Well, 6-MP and methotrexate are non-specific chemotherapeutic agents that can also kill white blood cells. And by killing certain white blood cells, you can tamper down inflammatory responses. Now, we're not going to use 6-MP and methotrexate to treat inflammation due to an allergy or inflammation due to a bug bite or an infection, but we can use 6-MP and methotrexate to treat chronic inflammation due to autoimmune disorders, right? I know some of you guys have seen that. And tacrolimus, you see tacrolimus that's used in stopping inflammation to grafts. A lot of individuals who have had transplant surgeries are on other drugs that act in other pathways to inhibit white blood cells attacking the graft, right? White blood cell attacking the graft is a type of inflammation. And again, inflammation being mediated by white blood cells, we take out the activation of certain white blood cell lines, we can minimize the individual's chance of developing a inflammatory reaction to the graft, right? So the question at the bottom says, why are all these drugs shown in purple considered to be anti-inflammatory? They're considered to be anti-inflammatory because they're taking out some key inflammatory mediator, right? They're specific, right? Diphenhydramine takes out histamine. Aspirin takes out prostaglandins. Does that make sense? So you look at this pathway here and you can see that we got a lot of different ways that we can target and treat inflammation. All right, acute inflammation. As you know, acute inflammation is red, swollen, warm, painful, and it's full of white blood cells. If you were to biopsy any of those inflammatory processes, right, you'd find a lot of white blood cells in there. Remember, inflammation is not always infectious. Allergens, irritants, autoimmune, etc. A lot of other things can cause inflammation. Inflammation often comes with systemic effects. So as those inflammatory mediators are released into systemic circulation, they can have some effect on the body. They can induce fever, general feelings of feeling ill, malaise, anorexia, chills, sweats, right? Inflammation, again, is caused by these inflammatory mediators. These mediators can be lipid or protein by nature. They initiate and perpetuate the inflammatory response by activating white blood cells. Lymphocytic B cells, lymphocytic T cells, macrophage, mast cells, right? These mediators can have multiple effects on numbers of different cell types. If you want to take another look at the different inflammatory mediators, take a look at figures 7-9. They're the same ones that I just had on the previous slide. Again, showing you there's a lot of different ways that we can get to activation of those mediators. Where are those mediators typically found? They're found within white blood cells. So take a look at that microscopic picture of that white blood cells. Of these white blood cells, you can see that there's granules within the white blood cells, and within those granules, we store those inflammatory mediators. When that white blood cell degranulates and releases the mediators, it calls more white blood cells to the party, right? So one white blood cell, by degranulating, can activate a series of more white blood cells to divide, to reproduce, and come to the site of inflammation, come to the site where we need control of the antigen, whatever that antigen might be. And when those white blood cells get there, right, those white blood cells are going to divide. Diapedesis, see that on the slide? Diapedesis means the migration of the white blood cell to the site of inflammation. Those white blood cells get there, and these inflammatory mediators there are going to have action on the blood vessel as well. It makes the blood vessel dilate and makes the blood vessel leaky. The dilation of the blood vessel makes the site warm. The dilation of the blood vessel and the increased blood flow makes the site red, and the leaking of the blood vessel makes the site edematous. So look at all of those pictures of inflammation, right, of arthritis, cellulitis, pharyngitis, dermatitis, orchitis, and you see that, right? It's all red and swollen. If you touched it, it would be tender and painful. It would feel warm. And if you were to biopsy it, you would find that it's loaded with white blood cells, right? So there's the acute inflammatory process summed up really quickly, shown to you in pictures. And again, emphasizing for you that it's these inflammatory mediators within the white blood cells which are initiating and perpetuating that process. More inflammation, right? Dermatitis, conjunctivitis, rhinitis, otitis. That picture at the bottom right is an inflamed tympanic membrane. So inflamed tympanic membrane, otitis, because that's the middle ear media, otitis media, right? One part of acute inflammation is the blood vessels are leaking, and the leaking of the blood vessels cause edema. And we can get different types of edema. We can get what's called serous exudate. So this is watery. It tends to have a few number of white blood cells in there. It typically doesn't have infectious organisms like bacteria. So this would be acute inflammation, maybe due to a virus, maybe due to contact, allergens or something like that, right? This you would look at this type of inflammation and say, yeah, that doesn't look like a bacterial infection. It's inflammatory, but it's probably not due to a bacteria, because that edema or that exudate is serous. It's relatively clear. And you've seen this. You've all seen this. As opposed to edema or leaking of fluid, which is really purulent, right? Or pus. And you know that when you see pus as part of an inflammatory process, you immediately begin thinking what? Right, bacterial infection. If you looked at serous exudate grossly with the naked eye, you see it looks very clear, non-turbid. If you look at serous exudate under the microscope, you might see some white blood cells in there, but you certainly wouldn't expect to see a lot of bacteria in there. If you look at pus grossly, and pus is gross, but when I say gross here, I'm talking about looking at it with the naked eye. If you look at pus grossly, you see that it's very thick and purulent, right? Looks disgusting, kind of smells disgusting. But then if you look at it under a microscope, you also see that it's chock full of white blood cells, and you also see that it might be chock full of bacteria as well, right? Think of it, whenever you're obtaining cultures on people to look for bacterial infection, you're usually swabbing and taking a culture of the pus, right? And you're submitting that to the lab to find the bacteria on the gram stain and find the bacteria on the culture and sensitivity. Sometimes pus is relatively grossly visible, right? Purulent conjunctivitis, right? Purulent urethritis, such as the individual with the raging case of gonorrhea in the middle there. Purulent sinusitis, looking up somebody's nose, looking at the red, swollen, congested nasal turbinate, but then also seeing the pus balls up there behind the turbinate, right? Tapping a knee, getting pus out of a knee, getting pus out of spinal fluid, finding pus in sputum, right? There's a lot of different ways that we can find pus. Pus is purulent exudate, which is part of that inflammatory process. So remember, I said not all inflammation is infectious and not all infections are bacterial. But when you see pus, you start thinking bacteria, right? And then that, again, in terms of therapy, then you start thinking, oh, antibiotics. Not only can I be treating this individual with some type of anti-inflammatory agent, but I probably ought to be using some type of antibiotic in managing them as well. All right, pus. Pus should be your friend. You should learn to love pus, right? Whenever somebody comes in and you're a clinician and they say my blank hurts, well, what do you got to do? You got to look at their blank. You may have to touch their blank and, see what the blank, is it warm? Is it tender? Is it swollen? And is there any evidence that there might be pus? The blank might be their leg. My leg hurts. My throat hurts. My ear hurts, right? Because inflammation is painful and swollen. And if somebody is complaining of pain and swelling, and you see that it's red hot and has pus, you're going to start thinking, what? Yeah, that inflammation might be due to bacteria, right? So you might be able to see the pus on the physical exam. You can always submit the pus. You can always submit the pus, whether it's coming from a urine or wherever you obtained it from. You can always submit that to the lab. You might have to find the pus with a needle, right? Such as draining an infected joint or getting cerebral spinal fluid in a case of bacterial meningitis, right? There's that itis thing again, bacterial meningitis. Inflammation of the meninges due to bacterial infection. You would expect to find pus in the cerebral spinal fluid, right? Turbulent, cloudy, CSF full of white blood cells and bacteria. Submit that to the lab. They confirm for you, yep, got a bacterial infection going on here. And then sometimes too, you can see pus on a imaging x-rays such as a CT scan or whatever, and we'll look at some pictures of that as well. All right, back to triggers. Remember, triggers can be bacteria, but triggers can be anything. When it's a bacteria, we tend to get pus. Usually means we're going to treat that with antibiotics, but not all inflammatory processes need to be treated with antibiotics because many inflammatory processes are not due to infectious bacteria. They're due to viral proteins, they're due to plant carbohydrates, animal saliva, chemicals, right? A lot of different things can cause inflammation. If the trigger is exogenous, meaning it's not part of our body, right, we would consider that to be foreign. So a foreign invader is an exogenous. But if it's our own antigens which are triggering the response, then we say that's endogenous or self-antigen, and those are the autoimmune disorders, right? So again, any tissue of the human body can suddenly present itself as foreign to the immune system, and if the immune system begins reacting to your own antigens, that would then be considered an autoimmune disease. So I listed some autoimmune diseases here. Type 1 diabetes mellitus, where the immune response is reacting to the beta islet cells of the pancreas. Rheumatoid arthritis, where the inflammatory process is targeting the synovial cartilage of joint. Multiple sclerosis, where the autoimmune disorder is targeting myelin of the central nervous system. Hashimoto's thyroiditis, where the autoimmune disorder is targeting the epithelial cells of the thyroid gland. Pemphigus, where the autoimmune disorder is targeting the dermal junction of the skin. All of those diseases that I just mentioned, we're going to talk about in more detail at some point in this course. Right now, what I'm trying to do is just introduce this concept to you of exogenous versus endogenous inflammation. And endogenous or autoimmune inflammation is always going to be considered abnormal. And there are a number of devastating autoimmune diseases because the body is reacting to self-antigen. And again, quick slide. Any tissue of the body can be affected by autoimmune inflammation. Here we're showing you a number of different tissue types and the different types of diseases that occur as a result of autoimmune inflammation on that tissue. Don't memorize any of this stuff right now. I know many of you are already familiar with a lot of these diseases. Hold on, as we move into the more detailed units, we'll get to most, if not all, of these diseases and talk about them in a little bit more detail. And again, this is just a quick review slide to, again, review acute inflammation. So take a look at that and then be able to understand how that all fits together. Here's some nice examples of acute inflammation. So top left, normal liver. Top right, acute hepatitis. And you can see the infiltration there of all those purple white blood cells. Lower left, normal alveoli. Lower right, the alveoli now swollen and loaded with white blood cells, alveolitis. We don't really call it alveolitis. What's the term that we really use when somebody's alveoli gets inflamed due to an infectious organism? Pneumonia, right? Yeah, so pneumonia, inflammation, infectious inflammation of the alveoli. Technically, I guess we can call it alveolitis, but we don't really use that term, right? We tend to say pneumonia more commonly. All right, again, that's just showing you, again, we'll talk about hepatitis and we'll talk about pneumonia as we move through the course, but again, just showing you some histology and trying to impress upon you in these acute inflammatory disorders, you should expect to see an infiltration and proliferation of these normal white blood cells, usually the lymphocytic cell line. All right, how about inflammation that goes on for a long period of time? Usually acute inflammation, we think of something that goes on for 5 to 14 days, right? Something that is typically going to be a self-limited response. Chronic inflammation now perpetuates and goes on. And what happens in a chronic inflammatory process is that the white blood cells now start to get replaced by another cell type called a fibroblast. And the fibroblast is what lays down the scarring of tissue. So one major way that we differentiate acute from chronic inflammation is not only the duration of the inflammation, but whether or not we're looking at scarring. If we're seeing connective tissue replacing normal tissue, scarring, right? That's what scarring is. It's connective tissue. Fibroblasts replacing normal tissue. That's called a scar, right? And what can that scarring do? That scarring can lead to loss of function of the tissue. It can lead to contraction of the tissue. It can lead to obstruction in lumens of tissue. It can lead to adhesion of one tissue to another, right? And this is all part of the chronic inflammatory process. And here we got a number of different chronic inflammatory processes being shown to you. Chronic arthritis. In the middle there, that's Crohn's disease. That's a specific type of scarring called a granuloma, which we will cover in the GI unit. Some skin scarring due to whatever different trauma might have occurred there. What is the picture in the middle? What type of chronic inflammatory process is that? Well, first off, ask yourself, what organ am I looking at? You see that's the liver, right? So that's a chronically scarred fibrotic liver. What's the term that we use for that? Cirrhosis. Yeah, very good. A lot of different things can lead to cirrhosis of the liver. One of the most common is alcoholic cirrhosis. We'll talk about alcoholic cirrhosis in the GI unit as well. And then here we see some chronic, we see gingivitis, right? Inflammation of the buccal mucosa, but because we see that white scarring and plaquing in there, you know that that's been going on for a long period of time. Let's try to guess why this individual has such bad, looks like maybe both acute and chronic gingivitis going on. Can we try to postulate what might be the trigger to that? Yeah, bad hygiene, dental infection, maybe smoking or chewing tobacco, right? A lot of different things can lead to that just gross acute and chronic gingivitis that you see in a lot of people with poor oral hygiene, particularly if they're smokers or using nicotine tobacco products in their mouth. All right, so chronic inflammation versus acute inflammation. Here's some examples of chronic inflammation on the joint. So chronic arthritis. So remember, arthritis is inflammation against the synovial cartilage. The synovial cartilage should be nice and moist and frictionless, allow movement of one bone on the other without grinding and pain. So there's a normal cartilage, and I'll look at the cartilage of an individual suffering from osteoarthritis, a chronic degenerative inflammatory condition of the synovial cartilage, and look at how that cartilage looks chewed up and ratty, right? Starting to be worn away. Eventually that cartilage is going to be gone, where you get to the point where, you know, no more synovial cartilage, bone rubbing on bone. Anyways, what we're looking at here, both in terms of the diagram, in terms of the gross physical examination of the patient's knees and of the biopsy of the synovial cartilage, what we're seeing is fibrosis, scarring, and destruction of the tissue. And in this case, the tissue being destroyed is the synovial cartilage, right? Chronic inflammatory processes. And then again, let's come back to this big scheme of white blood cells being activated by inflammatory mediators. So both in acute and chronic inflammation, we have mediators activating these cells. The lipid mediators, the leukotrienes, the prostaglandins, the thromboxanes, we tend to see that taking more of a role in acute inflammation. The protein mediators, the interleukins, tumor necrosis factor in particular, tending to play more of a role in chronic inflammation and definitely playing more of a role in chronic autoimmune inflammation. So we treat acute inflammation with things like antihistamines and steroids, non-steroidal anti-inflammatory drugs. We can use steroids and non-steroidal anti-inflammatory drugs for also managing some components of chronic inflammation, but it is these newer drugs, these drugs which are targeting tumor necrosis factor and targeting interleukins, these are the newer drugs that we're using to treat the chronic autoimmune inflammatory disorders. And these drugs are inactivating white blood cells because they're having some adverse effect on TNF or interleukins. And we're going to look at this in a little bit to wrap up this unit. Stremsky, what are you showing us here? My Lord, you and your biochemistry. Hey, you know, I'm totally into farm and I love this molecular stuff, but let me just show this to you just so you start to understand why Humira and some of these newer drugs like Xeljanz and other drugs coming out on the market work, and why they're used for this chronic autoimmune inflammation. There are a number of different enzyme receptor complexes which are found in white blood cells that activate these white blood cells, and one type of receptor enzyme complex is something called JAK-STAT. And this is a diagram of one of these JAK-STAT pathways. This receptor sits on the cell membrane of the white blood cell. The receptor gets activated, and the activation of the receptor leads to factors inside the cell that are going to turn on DNA. And when you turn on the DNA, that cell begins to function, that cell begins to divide and reproduce. And it's the functioning and the division and the reproduction of that white blood cell which is perpetuating the inflammatory process. So if you want to shut off the inflammatory process, one thing that you can do is you can shut off the JAK-STAT pathway. So what are some things that turn on the JAK-STAT pathway? One thing that turns on some of these pathways is a protein called TNF-alpha, tumor necrosis factor alpha. It's a complex protein. The protein is right there in the top middle of this slide. It's the thing that kind of looks like, it almost looks like a jellyfish, if you will. It's kind of got like the aqua ribbons with some red stuff in it, right? That's tumor necrosis factor. It integrates and acts on the TNF-alpha receptor, lights up, turns on that JAK-STAT pathway, and then that JAK-STAT pathway starts making the white blood cells do their thing, proliferate, grow, activate, perpetuate the inflammatory response. So let's do something in somebody who's suffering from a chronic autoimmune disease such as rheumatoid arthritis or psoriasis or Crohn's disease or ulcerative colitis. Let's do something to inactivate some of these JAK-STAT pathways and therefore minimize their chronic inflammatory disorder. So you're ready? Let's look at this. One type of drug, and these drugs have been out for a little while now, and more of them are being released it seems like every month there's a new drug being released to the market. This is a type of drug called a monoclonal antibody. So you know that an antibody reacts with an antigen. So in this case here of these autoimmune disorders, the antigen is either TNF-alpha or one of the interleukins, and the antibody is the drug. So adalimumab, Humira, ustekinumab, Stelara, and you can see the other ones that are on there. These are the antibody. Monoclonal meaning it's going to be a specific antibody which is only going to neutralize one type of antigen. So in the case of Humira, it's only neutralizing TNF-alpha. In the case of Stelara, it's only neutralizing interleukin 12. In the case of Cyrabi, it's only neutralizing integrin 4. So as more of these inflammatory mediators are recognized, and the more we understand which inflammatory mediators are specific for which types of pathologies, the better we can be at targeting pathologies with drugs like monoclonal antibodies. A good example, Stelara is used very commonly for individuals with bad autoimmune psoriasis and autoimmune psoriatic arthritis, but you wouldn't use Stelara to treat multiple sclerosis. Well, tongue-tied. I get tongue-tied a lot in these videos, so just like hang with me. It's hard for me to dictate videos talking to a screen. I like to talk to people, so here I am talking to a screen. Nonetheless, just hang with me with my tongue ties. All right, I'll try to untie at this one. Stelara can be used very effectively to treat psoriasis because interleukin 12 is has been found to be an important inflammatory mediator in psoriasis. Stelara is not going to be very good for treating multiple sclerosis because interleukin 12 doesn't appear to play a big role in there. What does appear to play a big role in multiple sclerosis is a different inflammatory mediator called integrin 4. And integrin 4 seems to allow white blood cells to get to and attack the myelin. So multiple sclerosis is a destruction of myelin. It's an autoimmune destruction of myelin. Integrin 4 tends to be a mediator of that, so we can use Cyrabi, natalizumab, to treat multiple sclerosis. Adalimumab targets only tumor necrosis factor, and tumor necrosis factor plays a big role in rheumatoid arthritis as well as Crohn's disease and ulcerative colitis. So Humira therefore becomes a nice drug for managing that. So you see what I'm trying to do for you here? I'm trying to tie to you the pathophysiology of chronic autoimmune inflammation, telling you that a lot of that is due to activation of white blood cells by inflammatory mediators. Those white blood cells are destroying self-antigens like synovial cartilage, like myelin, like GI tract epithelium. And what we're trying to do to minimize the effect of that inflammation on tissue is to neutralize the inflammatory mediator with these monoclonal antibodies. And I know that you've seen these, and I know that you're going to see more of them. They're coming out left and right, and it's kind of cool to see these things come out and see these things come out with different indications. Sync Air. I don't know if any of you guys have seen this. If you're in pulmonary, you may have seen it, but Sync Air is relatively brand new. Within a year, that's been released, and that's for managing chronic inflammation due to COPD. Pretty interesting. You would not use that one for treating rheumatoid arthritis because the pathophysiology there, the type of receptors and inflammatory mediators there are different. Cool stuff. Agree with me, right? Cool stuff. And then how are Xeljanz and Otezla different from the monoclonal antibodies? So the monoclonal antibodies are big proteins. They typically have to be given by injection in the same way that you got to give insulin by an injection, right? Insulin is a protein. You can't take oral insulin. You got to inject it into yourself. We're going to cover all the insulins in Unit 5. You're going to, well, I like talking about insulin, so we'll talk about insulins in Unit 5. But let's get back to inflammation here. Otezla and Xeljanz are small molecule drugs that you can take orally. And what these small molecule drugs do is they also inactivate the JAK-STAT pathways. Where the monoclonal antibody acts at the cell membrane to inactivate the pathway, the small drugs like Xeljanz and Otezla, they work inside the cell and deactivate the pathway from intracellular. You get the same effect. You stop the white blood cells from proliferating and doing their thing, and therefore you can better control the chronic inflammatory process and therefore minimize the harm done to the tissue due to the autoimmune inflammation. Maybe one of the benefits of Xeljanz versus Humira is you can take Xeljanz as a tablet versus having to get injected. They're both effective. Both these newer drugs, both these newer drugs, Xeljanz and Otezla, are as effective as the monoclonal antibodies. And when you get into the specific disease, we can talk more about, how is one chose over the other. Right now, I'm just trying to help you understand the pathways, the mechanisms of the pathways by showing you how the drug affects the pathways, right? So monoclonal antibodies taking out JAK-STAT pathways, Xeljanz, Otezla, similar drugs coming out on the market very soon. Do the same thing, take out the JAK-STAT pathways. They just do it at a different site within the cell. Cool stuff, right? You got to admit that a lot of this newer pharmacology is amazing. Do you ever use a monoclonal antibody together with one of these drugs? No, it's one or the other. You pick one way or the other. They're really never used simultaneously. They're just used one or the other, right? So if someone who's on Xeljanz probably should not also be receiving Humira and vice versa. All right. Ooh, this one's a little bit out of sequence, but again, we talked about chronic inflammation. Remember, chronic inflammation, a lot of chronic inflammation is due to autoimmune disorders. sometimes chronic inflammation is due to exogenous substances. So top slide showing you cirrhosis, chronic inflammation due to alcohol. Bottom slide, COPD, chronic obstructive pulmonary disease, showing you chronic inflammation leading to fibrosis and destruction of the lung due to cigarette smoke and the toxins in cigarette smoke. And trust me, because alcohol and cigarettes play such a huge role in human disease, we will definitely in this course talk about alcohol and cigarettes when we get into some of the specific units. All right. Woo! Check it out, folks. We're done. So that was 2 hours and 10 minutes. Now that's going to seem like a long lecture for you, but it actually was a short one. Remember, this was more of an introductory unit. When we get into the more hardcore stuff and start actually going through a bunch of different diseases, then these PowerPoint narrations are going to expand out to as long as 3.5 hours. And I swear to you, I promise you, I'll try to keep them under 3.5. But there's a lot of stuff to cover, so there's a lot of talking that I got to do. You guys will probably get sick of listening to me on these videos, but just hang in there. I'll try to keep it interesting. I'll try to keep it pertinent. I hope that you guys find the drug stuff interesting. I will not test you on any of the drug stuff. I'm using that as examples for you to help you out when you get to future pharmacology classes and help you out understand some of the pathophys. And like I said, I like that stuff, so I cannot not talk about that stuff. All right, the end of each PowerPoint video will have this wrap-up slide just reminding you of what are the assignments that I want you to take care of this week, both with respect to the quiz or the weekly quiz or exam and the weekly discussion boards. Again, please go through the content sheet every week and look at those instructions. Read the threads. Previous classes have done awesome on the discussion threads. I think that's the best part of the course, is seeing what everybody else thinks about the cases that I put up there and interacting with each other. And I think those threads are very helpful in helping you study for the quizzes and the exams. If you have any questions, send your questions directly to me through Blackboard. Through email, or post them up on Blackboard, and I'm usually pretty good about getting back to you in email. All right, I'm done. We're done for the week with this narration. Have fun looking at the content and getting the assignments done, and then I will see you next week when our next topic will be dermatology and talking about diseases of skin. All right, see ya.